Good afternoon, everyone. This is Morgan from the New England QIN-QIO, and I wanted to thank you for joining us for today's webinar, Interact Session 7 on Advanced Care Planning with Sheila and Carol. Florence is not with us today. She's on vacation. But before we get started, I want to go over a few housekeeping items. This call is being recorded for training purposes, and I'll provide you with details on accessing the recording at the end of the webinar. I'm going to go ahead and mute the phone lines real quick. All right, phone lines are muted, but we will be taking questions at the end, and I'll give you some instructions on how to unmute your line at that time. If you would like, you can pose a question in chat during the presentation in the bottom right of your screen. Please make sure to send the question to all participants so that we can keep up with the incoming questions. And with all of that said, I'm going to pass things over to Carol to get us started.
Thank you so much. Good afternoon, everyone. Hope you're having a great day. We are going to be talking about advanced care planning, the tools within the toolbox related to the advanced care planning for your residents. There you go. The objectives for today is to understand how to use the advanced care planning tracking form to provide residents and families opportunities to make informed decisions about levels of care. Develop a plan for sharing information on advanced care communication guidelines. Understand the MOLST program and the current status in Connecticut. And then develop a plan of implementation of these Interact tools for the use in resident care planning. With that being said, I always start off the session about the requirements to get your Interact participation certificate, because this is what your preferred providers are looking for, that you participated in this training and that you have implemented the tools. It's not just about listening to the training, but actually implementing the tools within the Interact toolkit. So, for 2016, these are the requirements. You must participate in 7 out of our 9 webinars. We are in session 7, so we have 2 left. So we need to make sure that you're going to be participating in 7 out of the 9 webinars. And you have to send Qualidine. You have to send myself, which is Carol Dietz, or Sheila Eckenrode, or Florence Johnson, at least 4 months of readmission data. Now, there's a couple of ways to get this done. The first is to be active participant in Advancing Excellence and to actually put your data into the Safely Reducing Hospitalization Tracking tool, which is part of the Advancing Excellence website. And you also have to, in order for us to be able to see your data, you have to sign the data use agreement with Qualidine, which we can get out to you and have you sign it, and then we can start looking at your data. So that's one way. Or the other way of sending us your data is if you're part of a corporate entity and you have your own corporate readmission tracking tool, send us at least 4 months worth of data by email. Now, we do not want patient-level data. This is an aggregate by month, your readmission rates. Now, the other way is, the final way is, if you don't have a readmission tracking tool, you're not part of Advancing Excellence, you can use the Interact readmission tool, which is part of the Interact website, which Florence, which is very similar to the Advancing Excellence tool, but it's on the Interact website. Or you can use the readmission tracking tool that we developed for the nursing homes for this year. We can send this out to you by electronically. You just have to put your data in, and it will automatically populate your readmission rate. We have information on how to fill out this form, and then you can send it back to us. Again, we want an aggregate on a monthly basis. We do not want patient-level data. Just wanted to share with you, and then finally, one more thing that has to get done. This is part of the participation agreement that was signed by your administrator at the beginning of this journey of 2016 is at the very end of our last session, so end of November, we're going to be sending out the Interact Tools checklist to your administrator, and they need to check off which tools have been implemented and are part of your environment of care for your residents. And then they're going to sign the form to document saying that, yes, we are using these tools. So those are the three requirements. Now, with after each webinar, we then put the recording, as well as the slides, as well as the transcript up on our website. And on this slide, you see that the New England QIN-QIO website. If you want to re-listen to a session, or if you have missed a session, you're only allowed 2 missed sessions. And again, Julie is keeping track of this for us, that you can listen to online, and you will get counted for it, but only 2, not 3, not 4, only 2 can be listened to online to be counted for that 7 out of the 9 webinars. And this is how to get onto the website. You click on events, you're going to scroll down to previous events, find the month that you want to listen to, and then find the webinar. And because once you click on the webinar, they're going to ask you for your name, ask you for your facility. So make sure you put down the facility you're listening for, not just an acronym, or write the whole facility name so we can track it appropriately. Just wanted to share with you some statistics up till now. We have a total of 58 nursing homes that have listened to, that have signed the participation agreement with us. As of right now, we have 15 nursing homes that have participated in all 6 previous webinars. So congratulations to those 15 nursing homes. And we have 4 nursing homes that have sent us at least 4 months worth of data. So there's a lot more of you out there that need to get this ball rolling. Because again, we will not accept the data after January 2017. So you want to start sending us your aggregate data. So these are the Interact sessions that we've had so far in 2016. So this slide will help you identify those sessions that you may have missed, 1 or 2 that you may have missed. So this is just a great resource slide for you. So without further ado, I am going to turn the microphone over to Sheila Eckenrode, who's going to be talking about the advanced care planning tools in the Interact toolkit.
Thank you, Carol. Good afternoon, Interact partners. I'm glad to be with you today. I want to talk to you a little bit about the advanced care planning tools as part of the Interact quality improvement system. I know that every facility in Connecticut has some sort of policy and some sort of procedure on when to use advanced care planning tools and how to obtain DNR orders or do not hospitalize orders. But if you feel that your facility could use a refresh, you can open up these tools. They're ready to go. You can make this your policy. So within the Interact system, we have advanced care planning tools that include a scripted guide, very helpful, especially for maybe new nurses, maybe new CNAs who aren't used to having these types of discussions. They can be part of a resident care conference. That's a perfect place to incorporate these tools, and using the tool will ensure that the discussion is recorded and can be accessed by other caregivers. Part of the toolkit available in Interact has resident and family education materials on hospitalization, CPR, and tube feeding, and a guide to when palliative care is appropriate. And this is what they look like on the webpage, right under Care Path. So again, as we always point out, the purpose of Interact is not to fill out forms, it's to guide processes. So these tools are really prompts to help us do the right thing every time. The advanced care planning tracking form that I just mentioned, really simple. It's just, did you have the discussion or not? And if you didn't, why not? If you introduce the topic, or if you're a care coordinator or has a registered nurse or your APRN, introduce the topic of advanced care planning, when to go to the hospital, that type of thing, CPR, intubation, and the patient or resident did not want to talk about it, you can see there's a little checkbox that you can say it. If you didn't introduce this topic, I would encourage you to ask yourself why not. Because sometimes the reluctance is on our part, not on theirs. There's some good information, good patient education and family education information about deciding about going to the hospital. And I think that this is one place that we don't really provide a lot of education to patients and residents. And when the patient's family especially says, I think you should go to the hospital, we just kind of say, okay, you made that decision, but we can help people. We can help people make a better decision by giving them more information. So there's some good tools in Interact to help with that. For instance, we can say to residents and their families, these are the things that the hospital can do for you. You'll have access to tests and x-rays and scans. There'll be specialists and doctors visiting every day. That's something we can't necessarily do in an SNS. If you need surgery, that's available, and there's an ICU. All right. Here's why we would go. How about the risks of going to the hospital? And I think we very rarely tell residents or their families what they are. New and worsening confusion, more time spent in bed. We used to have this cynical saying in the hospital that if you walked in from a nursing home, chances are you won't walk out because we're not going to get you up. More time in bed results in a higher risk of pressure ulcers and blood clots. Debilitation. Elderly people don't sleep and rest well in hospitals. The lights are on all night. It's noisy. There's overhead paging. Many older people and skilled nursing facility residents fall in the hospital, and you know that better than I, and come back with some cuts and bruises, broken bones. New infections, I think most people are pretty aware now. The public is aware of all the nasty bugs that live in a hospital. And hospitals can be depressing. So, talk to your staff, talk amongst yourself, and get a degree of comfort in discussing these things with residents and their families. The time for this discussion is very rarely the moment you're getting ready to transfer someone. It needs to come earlier than that. It needs to happen when you realize that somebody has a change in condition that might require hospitalization. Begin to talk about it then. I want to talk a little bit about palliative care. Almost every hospital in the state of Connecticut now has a palliative care department. You might have access to palliative care in your own facilities. Palliative care is an approach that improves the quality of life for patients and their families facing life-threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment, treatment of pain and other problems, physical, psychosocial, and spiritual. That's the World Health Organization's definition of palliative care. When is palliative care appropriate? Palliative care is appropriate at any point in a serious illness, and I would encourage you to think about that when you think about your residents, because your residents all have serious illnesses or they wouldn't be living with you. So they're really all appropriate for palliative care. Think of palliative care as another layer of care, concern, and support for residents and their families. So I would encourage you, anytime you send one of your residents out to the hospital for any reason, to request a palliative care consult when they're there if you don't have access to that yourself. Palliative care, again, is more integrative. You're hoping to integrate psychological and spiritual aspects of care using a team approach offering support systems to families, and offering supports that will allow patients to live a good life, regardless of their illness. Again, I can't stress this enough. Palliative care is appropriate at any point in a serious illness, even when it's newly diagnosed. So think about that. Palliative care is not a fork in the road the way hospice is. You know, we always think of a patient on hospice now has no what we might describe as advanced treatment or even aggressive treatment. That's not true of palliative care in the hospital. You can request palliative care for one of your residents, and even while they're undergoing chemotherapy and surgeries and all the rest of it. So be mindful of that, because really anybody in a nursing home could benefit from this type of care, this intervention, when they go to the hospital, or if you are lucky enough to be able to access it within your own SNF or in your own community. So, when I talk to folks in skilled nursing facilities and Medicare beneficiaries as well, there's always a bit of confusion as to when is the right time to start thinking about things like hospice. I already said palliative care is always, you can always ask for that. But when you think about hospice and you think about talking to your residents about moving towards comfort care and away from medical interventions, how do we know when the time is right for that? It's confusing, I think, to patients because we, meaning doctors and nurses and people in healthcare, are in the business of treating and hopefully curing diseases, and we throw ourselves into that headlong and with great enthusiasm, and then one day we say this isn't working. And in our minds, that can pivot pretty quickly, but in the mind of a resident or their family, that's a little hard for them to shift gears. Sometimes the change in the resident is visible. You see somebody becoming more frail, unable to eat. That's a little bit easier to understand than us realizing that the rejection fraction has worsened and their chances of recovery are poor. So another tool that Interact gives us is some guidelines about when hospice care is more appropriate. So you see on this slide we have CHF, symptoms of dyspnea at rest, serum sodium levels less than 134. Anytime somebody with CHF, chronic CHF, is admitted to an ICU for an exacerbation, you really have to think about, is this the beginning of a different phase of that illness? Because we know that it is chronic illness with a very high mortality rate. Same thing with COPD. Here's some guidelines for changes in the status of a resident with that illness that might prompt you to begin a conversation about hospice, begin a conversation about being treated within the facility versus going out to the hospital. And dementia, and that's a big one, because people with dementia, the course is so twisty turning. Somebody with dementia can look really pretty frail and ill, and one day you'll walk on the unit and they just jumped out of bed and are running down the hall, and you say, wow, how did that happen? But certainly anyone who has difficulty eating, a decrease in weight, decreased ability to communicate is in the beginning of the end stages of dementia. So just some prompts to think about during your resident care conference when you're looking at the care plan, but also when you're conferring with your APRN or MD and you're looking at some of these symptoms and have that discussion amongst yourself. Is this a time when I would advocate for my resident to receive hospice care? Okay, so they also, in this toolkit, have some good examples of comfort care, and I like these because, again, it's sort of like not all or nothing. So they talk about oxygen without monitoring SAPs. So you can have as much oxygen as you need, or you can take it off if it's bothering you, just to keep them comfortable. Running a fan across somebody's face who's having trouble breathing. Using opiates for dyspnea, really effective. Talking about minimizing vital signs and lab orders, and liberalizing a diet, which is very much appreciated, I think, by everyone. So, again, advanced care planning. We want to use these tools to frame the conversation, not just to fill out another form, and it needs to be part of an iterative process. We do it over and over again. This isn't one conversation. I think in long-term care, we're pretty good at having that first one when somebody walks in, and then maybe not in 3 weeks, and not in 3 months, and not in 6 months. So it's important to, every time there's a resident care conference, to think about advanced care planning. Anytime there's a change in resident condition, anytime there's a worsening of disease or symptoms, we want to allow residents and their families to be as specific as possible in choosing the care that they want. And I'm pleased to say that hospitals are now moving towards that. It's not this you buy the whole thing or buy nothing. Wanted to give you a little update on MOLST and POLST. For those of you who haven't heard this acronym before, it stands for Medical Orders for Life-Sustaining Treatment. POLST is Physician's Orders for Life-Sustaining Treatment, and there's also POLST, which is Clinician Orders for Life-Sustaining Treatment. 27 states in the U.S. now have these orders and honor them. The purpose is to provide a physician order for life-sustaining treatment across the continuum of care. So if you have the experience of admitting someone into the hospital, if that person doesn't have a DNR but has an advanced directive, we usually have to find a physician to then write a code status, to write for a do not intubate status. This is the physician's order that would go with the patient, so there's not that scrambling to find a doctor to write these orders. We have piloted it here in Connecticut. I believe the pilot began in April 2014 and was scheduled to end April of 2016, but I haven't heard of it becoming permanent. I believe it was piloted in the Hartford and Wyndham communities, so I'd be interested if any of the skilled nursing facilities from that part of Connecticut have experience with this, and to share with us what it's like to use. I want to say that here in Connecticut, the form is lime green. Don't know how I came up with that, but it's supposed to pop out, and I guess it does. Again, as I said, more than half of the U.S. states are using it. It began in Oregon in 1991, so we're still waiting for that to become legislation here. The people who would benefit from this type of order set are people with chronic progressive illnesses, serious health conditions, certainly medically frail people. They use as a tool for determination. You wouldn't be surprised if this patient died within the next year. And I think we can say that about a lot of our residents, right? Okay, so Carol's going to just take a moment to update us again about the red envelope, the use of the W-10, and some of the other things that are going on in our communities. But thank you for your time and for your advocacy for patients with chronic illnesses and at the end of their lives.
Thank you, Sheila. That was outstanding. Well, before we go on to talk about the DPH blast, Sheila did ask if there was any nursing homes that have seen a MOLST form in their work with their residents. If you could, if you are one of the nursing homes that have seen a MOLST form, and how did it work, and if you could hit #6 to unmute your line, we would love to hear from you. Anyone have seen a MOLST form this year?
Is this part of the pilot?
#6 to unmute your line, or you could also just put it in chat. We're just wondering if any of the nursing homes have seen the piloted MOLST form. Okay, well.
Sounds like that pilot needs to expand.
Okay, but thank you again, Sheila. Okay, so as you know, Florence isn't here today. She is on vacay, so let's all wish her well. But one of the things that she wanted us to make sure we did talk about is, we'll get back to those chat in a minute. Thank you. Is to make sure that everyone is aware that when you do an acute care transfer and you follow the guidelines for the red envelope, that you are using the Interact transfer form, the acute care transfer form, and you fill out the front of the form in completeness. You also send a current copy of the medication list for your resident, also their advance directives, as well as a copy of their face sheet of their chart. Because on the face sheet gives the patient's actual location of where they live if they're not living in your nursing home, if that's not their permanent residence. Also, they give the insurance information, and that's part of the public health code, that these things must be transferred with the patient so the care can be continued on to the next setting. So if you follow those guidelines, you do not need a W-10. So that's what this fax blast that came out last year, August 20th, 2015, DPH identified that the W-10 is not the required form. It's the data elements that's part of the public health code. The data elements, the data must be transferred with the patient. So that's why that W-10 form was created back in 1987. DPH was just trying to create a form that would be easy to use. We have now outgrown that form into using the Interact acute care transfer form. So it's the transfer form, the SBAR form, which tells the hospital why you had to contact the doctor, what kind of recommendations you were looking for, and why that patient's being transferred. So the SBAR form is very important. And it's the list of all the medicines that the patient's on, most current medicines the patient's on, the advance directives, and a copy of the face sheet. So those things go into the red envelope, seal it up, but before you seal it up, you also make a copy for EMS. Remember, EMS gets that second copy. They are not to go into that red envelope. That is only for the emergency department to go into. So I was at a conference over the weekend, and I was talking to some EMS professionals out in the New Haven area, and they stated to me that there were several nursing homes that saying that, all the information you need is in the red envelope, go get it. And I promised them that I would let the nursing homes know that that's not appropriate. You're supposed to be sealing up that red envelope, and only to be opened by the ER staff, because EMS gets your own second copy. So you have to make 2 of everything except the capabilities list. EMS doesn't care about your capability, not that they don't care, but they don't need it. But they need the medication list. They need the advance directives. They need to have that face sheet, and they need to have that transfer form. So those are the things you have to make second copies. And when we had our think tank with our nursing home group along with their stakeholders, we had about 20 nursing homes sitting around the table saying, yes, we can do that. We can provide that second copy. Yes, it adds a little bit of a burden, but it's important to make sure that none of those other forms in the red envelope gets taken out before that patient reaches the ER. So that's why this is really important. Okay? I'm going on and on and on, but I just want to make sure everybody understands why that second copy for EMS is so important. So let's go back to, we had 2 participants talk about using the MOLST form while working in SW, what's SW?
I think she's a social worker.
Oh, social worker, as a social worker in New York. Okay.
She also.
Oh, and well, the same person said the MPs or the MDs would complete this form. Outstanding. And I would love to hear from you, Kara, on how it was working, how it was accepted. Oh, okay, and Gloria Jones said I've never seen it. Okay. But it's interesting. Again, the pilot is affecting only a little small area of the state, so I'm not surprised that many of us haven't seen it. But it is just an order form that state, and it's filled out with the patient and the doctor are filling it out together. And then the doctor signs it saying this is what the patient has agreed upon. So it is a physician order. It comes with the patient. It's with the patient with their documents about whether they do want to be intubated, whether they do want CPR, whether they do want to be life-sustaining medications. So it is a pilot, as I said, and as we get more information, we'll be sure to share it with the group. So thank you, Kara, for letting us know that you have seen it in New York. Okay, as we always do, we go over our homework from last month, and you get new homework for this month. So let's get the ball rolling. So from last session, which was session 6, this was the big month of getting your acute care transfer process in place and updated with the Interact tools. So prior to your team meeting, your Interact meeting, the team leader was supposed to download the SBAR form and the nursing home transfer form and the acute care transfer checklist and the capabilities list from the website. Make copies of each of the tools so the team could review them all together and go through them one by one to make sure everybody understood what was going on and what needs to be done. And also you were going to move those tools over to to one of the shared drives of your computer. So if you were not there one day and they ran out of the forms, someone in your office could then continue to download these forms and not have to go onto the website to download the forms. Also, the team leader was supposed to talk to your purchasing vendor, your facility vendor, to purchase red envelopes. Now, again, we don't have any vendors here, so you're going to have to talk to the paper vendors, like who provides you with all your paper goods, to see if you can purchase red envelopes from them. And again, you want to make sure you have enough of them and you want to make sure you stack all the units once you have spread the intervention throughout the facility. But you wanted to make sure you have that up front before you start the process. You also wanted to look at where your copiers are located. If you only have one copier for the entire facility, you want to sit down with your team, and the nurses who are frontline staff to say, okay, when we do an acute care transfer, it is truly a team sport. It is not one person who does this, because one person needs to stay with the patient and filling out the SBAR form and filling out the acute care transfer form. One person has to be calling 911, obviously. Another person needs to be making 2 copies of all the forms while the ambulance is coming, and getting the patient ready for transfer. So it takes more than one person to do an acute care transfer correctly. And each time shift staff should be practicing putting this process in place for day shift, evening shift, and night shift. And working with your nursing supervisors, because obviously they'll probably be leading the transfer, but you want to make sure that everyone's on board and who's doing what. Everyone has a role, and then once that patient has been moved out by the ambulance, a quick debrief should happen to say what went well and what didn't go well, because you want to make it a better opportunity for the next time it happens. And then this, also, you're going to be not only looking at the copiers, but how about all the other supplies, the paper, the toner, everything that goes with the copier. You want to make sure, and you want to find that person who's going to be maintaining those supplies on a daily basis so that night shift nurse isn't running around looking for paper because somebody didn't add the extra paper before they left for the day. Also, you're going to have a second team meeting. You're going to schedule 2 meetings, one to talk about the actual tools, and then the second meeting was to actually map out your process, your new acute care transfer process. But during the first team meeting, you're going to review the tools. You're going to discuss how and when your staff nurses and your supervisors and your leadership and medical director are going to be educated on the tools. Decide where the copiers should be located. You know, once you've found your copiers, are they in the best place? And you're going to work with leadership to make sure that if you needed to be moved, that you get their permission. And you also want to make sure that the red envelopes have been ordered. During that second team meeting, as I just mentioned, you're going to map out your current acute care transfer process. And you're going to bring in staff nurses to make sure that they're part of the process, because you may map out this totally beautiful of how things are going to go, but they can actually tell you how things really go. So that's why you want your frontline staff to be part of this meeting, and to make sure that your documents, these new tools, are in places that are easily accessible and easily to be copied. And then you're going to decide which unit's going to roll out this new acute care transfer process. You're going to start small, start with, your first unit, and the next time a patient has an acute care transfer, that's when they're going to start using the new process, and then you're going to debrief after it to make sure it went well. So let's talk about it. Let's see how, I would like to open up the phone lines, and yes, we will be picking on people, even though Florence isn't here, her spirit is with us. And so we will be, if we don't hear from people, we will just let you know how things went this month. This is huge. The hospitals are looking for this. We are spreading this word around the state to all the emergency departments. I'm going to be in front of all the emergency directors next month to talk about the red envelope, to talk about what is expected once you see a red envelope. So let's talk about internally how things are going with educating the staff and looking at the copiers, and are you ready to roll it out? So pound 6 to open up your lines. I'd greatly appreciate it if somebody could start off the discussion.
Hi, it's Jack with Simon Lansdale.
Hi, Jack. Thanks for starting us.
Oh, you're welcome. We've been doing it, but we do, like last meeting where we said, to make the third copy, the system has been that we make the third copy, keep the copy for ourselves. I don't want to change it because it's working great. I mean, the red envelope, the copier is right there at the nurse supervisor's office. So everything's been working smoothly.
Excellent. Thank you. Perfect point. You're absolutely right. I'm just thinking about a copy for the red envelope and a copy for EMS, but you're absolutely correct. That third copy goes into the patient's chart. So thank you, Jack. Thank you so much. You get the star for the day. I'll be sure to tell Florence.
Yeah, tell Florence my best, so happy vacation.
Okay, thank you. Thank you so much. Okay, pound 6.
This is Bob at Birmingham.
Hi, Bob.
We're working with Griffin Hospital. We're part of the preferred provider network, and it's been a requirement for them for a while for us to be working with the Interact tools, especially going along with the red envelope and clinical capabilities and all of that. So we've been kind of doing it for a while. It works out well, and it's a bunch of steps involved, but I guess in the long run it helps out, and at least gives them a decent amount of information when residents first get admitted there for quick treatment.
Excellent. Have you got any feedback from Griffin, from the ER staff, saying this information is so much better and it's so much easily readable compared to the W-10? Have you got any of that feedback?
I hear that they're happy that the information is going in, and they're still working training some of the ED staff there, sometimes not really taking a good look at the clinical capabilities. I mean, we have the waiver for IV Lasix and the Solumentrol and things like that, and it's clearly posted, and sometimes they'll still admit somebody just to provide the services that we could do here at the facility. So they're still working with that as well, too, on their end of it. So it's not just what we're doing, it's what they're doing once they get the information. But it's an open dialogue, and it's getting better.
Excellent, thank you. So that's the key. It is an open dialogue, and I know you, Griffin has monthly, if not quarterly, community meetings, and that's a good time to bring up that information again, saying, you know, remember, we are sending our capabilities list. Please have your ER staff look at it before they make a decision. And on that capabilities list should be an active, a live phone number, not a phone number to the admission desk who is only there Monday through Friday, 9 to 5. But it needs to be either to a supervisor who has an active phone. So if they do have a question in the middle of the night or the middle of a day shift, they can call that number to ask the question, can you do this? And instead of having to wait and be put on hold. And so that's why those phone numbers on those forms are so important. And you should look at those quarterly to make sure that the phone number is still active. Okay? So thank you. Thanks, Bob. Great insight.
You're welcome.
So anyone else want to share how things are going? Any bumps in the road, any barriers that you found that you can share with your colleagues so maybe they can help you overcome this barrier? Pound 6. Sheila's telling me to wait. She says I'm talking too much. Okay, why don't we pick on somebody then? Do. Okay. I'm sorry? So pound 6. Gina Gentile, are you, can you get on the line? Pound 6 to open up your line?
Hi there, I'm here.
Hey, so tell us how things are going with the red envelope.
Things are going well. We've been using the red envelopes for a while now. It's required with Middlesex Hospital. They seem to be appreciative of, the information. I did just ask them about making sure our par levels for the red envelopes are up to date, and that we're constantly checking on those. But the information seems to be concise, and all three staff shifts are. All three shifts are using the process too, and we've been doing drills, so it's been good.
Great. How about for EMS? Has there been any making that second copy for EMS? Has that been an issue?
No, it's never an issue, no. Because we have a second copier downstairs if something should happen to the top, the one upstairs. But no, it's been fine.
Excellent. Well, thank you, Gina.
Thanks.
Excellent. Thank you. How about pound 6? Does anybody want to also? How about your conversation with your medical director when you started using the SBAR tool, or starting using the acute care transfer, the red envelope? Any feedback from your medical director? Have they received any feedback from the emergency department? How about Kara Delaney? Could you pound 6 to open up your line? Kara Delaney? Come on. I see that you're on there. But it's really important to share with each other. Especially for those facilities that have been using the red envelope for a while, it's really nice to share with the issues that you had and how you overcame the barriers. Because it's lessons learned that can really help your fellow nursing home colleagues to put the right process in place.
Hello?
Hi, this is Carol. Who is this?
Hi, this is Gloria. And so we've one of the barriers that we initially had was that the supervisors were feeling overwhelmed with all of the information on the SBAR, and I think what really helped was realizing that not all the information is necessary, and so the information has to be specific for why you're sending someone out. And so I think reinforcing that with all the supervisors really helped for them not to feel overwhelmed, to know that there are some things they don't need to complete if it's not applicable. And so that's been very helpful.
Excellent, thank you. So that's really helpful. So, you know, it goes by the systems assessment, and as Gloria just said, if it's not applicable, you check the box, NA. So that will help cut down the amount of writing and box checking that the supervisor or the nurse that has made the assessment has to complete.
If you're sending somebody out with difficulty breathing, you don't need to assess their bowels, but that is such a difficult behavior for nurses to change, because we see a box and we just have to check it. We have to fill out that line. So
we're used to doing all of that, and so we have to learn to cut back.
Exactly.
And we've learned in nursing school that more is more, that we document everything. So yeah, I applaud your staff at being flexible and changing a well-worn set of behaviors there. Good for them.
Exactly. And that's what Interact is all about. It's really about making the work environment safer for the staff and safer for the patient. And, you know, we always focus on the resident. That's why we do what we do. That's why we're in healthcare. We all want to help someone. We want to help our residents. And so it's really changing a culture. And as Sheila just said, you know, I'm a nurse from way back, and the more I write, the better it is, but not necessarily. You know, we need to be much more succinct on what our requests are, what our recommendations are, and what our actions are. So thank you, Gloria. That was an excellent point. I'm going to ask one more person to talk about the red envelope, because this is, of all the tools, I mean, they're all very important, and we want you to incorporate all the tools into your everyday work life. But this is the one that, because it goes to the outside, it goes to the emergency department, we want to make sure that it's in place correctly. So with that being said, how about Meg McKenzie? Meg, are you on? Meg, can you pound 6 to open up your line? Okay. How about Richard Bates? Richard, are you on? Can you pound 6 and open up your line? I'm going to tell Florence. I don't think you want me to do that. Hi.
Hello.
Hi. Hi, is this Richard?
Yes, it is.
So, Richard, tell us about how things are going with your red envelope in your facility.
Well, we've enacted this quite a while ago, and it's going well. We've basically stayed on top of the program, and we're using it for both sides of the building. So we've been using it with Griffin for quite a while.
Great. And what was the biggest hurdle, if you think back of when you first implemented the red envelope and all the different tools that go in it? What would you say would be, what was the biggest hurdle that you had to sort of...
Well, I think the biggest hurdle was to get all the nurses on board to understand the importance of it and to utilize it. It was just getting them to understand the importance.
Okay. So did you have educational sessions weekly, or did you have just one big one, or do you have huddles in the morning to continue to stress the use of them, use of the tools? How'd you do it?
Well, what we do, they have multiple educational meetings with the staff on different shifts and stuff. And what we do is in morning report, if there's a situation comes up, we use that tool and go through the analysis. Here, the DNS just walked in. She was in a meeting. Hold on. They're asking about the red envelopes. I said we've been implementing them for quite a while.
Yep.
And I said one of the most difficult things was to get all the staff on board to understand the importance of it and to use it.
Yeah, red envelopes, that's actually going pretty well. Initially it was, why are we using it? Some of the ambulance services, seemed to be almost a little hesitant or made little comments that people didn't really care about them. But we still insisted we were using them.
Excellent.
Personnel, their own copy, red envelopes to the hospital. We were having a little shortage on red envelopes, sounds like, in the area, but we've been able to find some more. And that seemed to be a common thread with a few of the area homes as well. But red envelopes are going great, really.
Excellent. And Deborah stated on the chat box that they found that Amazon has the cheapest prices on red envelopes, on red folders. So that might be another area for you to look into for red envelopes.
Yeah, I think that's actually one of the places we located them.
Excellent. So thank you, Deb, for that great referral to go to Amazon. Well, thank you. Thank you so much, Richard, and thanks for your nursing director to jump in for you to talk about the process. So good. Excellent. Great discussion. And again, you can, for those facilities that are just starting the process, if you have any questions or concerns, you can always reach out to Sheila, myself, or Florence, and we can help you help get that process in place. So let's talk about homework for next month. So you're going to be downloading the Advanced Care Planning tools and the communication guide from the Interact website and make copies of the tools for your team to review. So you're going to be looking at the Advanced Care Planning tracking form, the patient education for going to the hospital. You're going to look at the guidelines for identifying residents appropriate for hospice and for palliative care. And you're also going to be looking for the examples for comfort care interventions. And then also the team leader is going to download these tools to a facility computer on a shared drive. So again, as these tools are running out, if you run out of copies, you can just go right into your computer and make copies instead of having to go to the Interact website. So during your next team meeting, you're going to review the tools. You're going to discuss how and when the staff nurses, social workers, supervisors, your leadership, and your medical director will be educated on the use of these tools and decide which unit will start using these tools once the education has gone on. You should also develop a timeline to define when the education will occur and then when the tools will be rolled out. And then whenever you start a new process, you always do a debrief after the first time and the second and the third time it's used to say, how is it going? How is it going? What could we have done better? And what else do we need to put in place? Also, one of the things I don't think I've talked about enough is that whenever the Interact team gets together, or the quality improvement team who's putting this quality improvement program together, because that's what Interact is. It's a quality improvement program for nursing homes. You should always be looking at your data, your readmission data, whether you're using the readmission tool out of on the Interact website or Advancing Excellence or your own corporate tool. You should always be looking at your data, find out where your readmissions happened. You should be, what day of the week, what physician, to see if there's any trends, and then what can you do about it. You need to do a drill down to find out, are the stop and watch tools not being used on a certain shift or a certain unit because the patients are not being assessed quicker enough because the stop and watch tool isn't being used. So you need to see your data because that will help drive the work. So I can't stress that enough. So with that, I'm going to open it up one last time to see if you have any questions for the team here about any advanced care planning tools or any other tools that we've been talking about. So *6 for any questions. #6, I'm sorry. Not the *6, it's #6 to open up your lines. Okay, anyone have one last time, #6? If anyone would like to ask a question concerning any advanced care planning questions or any Interact tool question, broadly. If not, I'm going to turn the microphone over to Morgan for a couple last minute and a half. Thank you.
Alrighty, you guys have heard me say this a million times, but as you close out of this webinar, the evaluation will automatically pop up on your computer. If you could fill that out, we would greatly appreciate it. If you don't have time to fill it out right now, or you're sharing the computer with somebody, you will receive a link to the evaluation in an email tomorrow. That email will include a link to the event page on our website that will have the PowerPoint presentation, which is currently there. And in the next few days, the transcript and recording will also be added. And then be on the lookout for emails about our next webinar on October 26th. October 26th, covering acute change in condition tools. And I want to let you know there will be a different phone number next month. We had a double booking, unfortunately. So you will get the new phone number information to your automated email confirmation as well as the day of details email that comes the morning of the webinar. So just be on the lookout for that. Thank you again, everyone, and we'll talk to you next month.
Thank you. Bye, everyone. Have a great month, and reach out to us if you have any questions. Have a great day.
Bye.
The reader has disconnected. The conference will be terminated in 5 minutes.